Well, good evening, everyone. Can you hear me? Can everyone hear? Wonderful. We're all set. My name is David Lowry, and I want to welcome you to Holland Hospital. I'm one of the physicians on the medical staff here. I don't work for the hospital, but I'm in private practice at the Brain and Spine Center, and I'm happy to bring the vast majority of my cases here to Holland Hospital. They have done a fine job for people that I treat. What I'll be talking about this evening is laser spine surgery, help or hype. There's a lot of marketing driven toward this concept, and we'll discuss that at some length. And at the end of the presentation, we'll have some time for question and answer. So we'll get started. So my own background, I went to Hope College, and after that went to medical school at Johns Hopkins, and then did a neurosurgery residency at the University of Pittsburgh for 7 years. I was in Grand Rapids initially the first 5 years or so of my practice, and then came out to the Lakeshore in 2005. It's common now for physicians giving talks to give disclosures so that you're aware of any potential financial conflict of interest. I am a surgeon, and so of course with that comes a bias toward surgery, arguably. And I've done some medical device development on a number of projects over the years, none of them directly related to this, however, and most of them in the spine. We're not talking about any of those this evening, though. So what does laser bring to mind for any of you? Maybe something like this. It's an early 1950s sort of version. Broader reality, of course, when we think about laser, we can think of laser beam or a laser pointer. Cats love these things. If you go to YouTube, you'll see all kinds of interesting videos on cats and laser pointers. You may think of laser tag or even a laser sailboat. And I mention this because you'll see a lot of these over the summer on Lake Makatawa. They look like a little sunfish, a glorified surfboard with a footwell. You can see the red spot on the sail, and that's how you can spot a laser sailboat. There we go. So what is laser? It's an acronym, and it stands for Light Amplification by Stimulated Emission of Radiation. It's a device that generates a narrow and intense beam of a single wavelength only by stimulated emission of photons from excited atoms or molecules. It's sort of a non-technical definition of really what laser is. I think intuitively, though, we all know what we're talking about here. In medicine, lasers are used in multiple fields. These are just some easy examples in cosmetic surgery and eye surgery, or multiple dental applications and oncology, both for lining a patient up precisely to receive radiation and also with use of many tumors, treating many tumors, control of bleeding. So what does spine surgery bring to mind? We'll get to laser spine surgery. We'll bring all these ideas together. Initially, people may think of something like this, a very big spine surgery, or something like this, another variation of that. The broader reality, though, is that many people who have productive lives and continue to be very active have had spine surgery, including Bono, President Bush, President Kennedy, Rick Perry, Jennifer Grey. She was in, I think, Dirty Dancing and some other things. And this guy, who may be recognizable. Of course, our most recent champion quarterback Super Bowl. He has a couple of those. And he's, of course, had neck surgeries that have been in the news. So what does laser spine surgery bring to mind? For many people, it probably has something to do with this. There's a practice initially in Florida that has marketed heavily in print media and online, and in much of their marketing is an image of a Band-Aid indicating a very small incision, and there may be depictions of a person who's returned to their normal life, which is a wonderful thing. That's obviously the goal that we would have for any of our patients. There's some implied promises laser spine surgery. And here now I'll move to that concept and move away from the direct reference to any particular practice. There's this idea that we all have, I think, of a small incision, a process that's minimally invasive with minimal tissue trauma, with a fast recovery and a full recovery. There's this idea, I think, some people have in their mind that with this approach, they're back to playing tennis or golf the next day or something of that sort. And we'll talk about that as the talk goes on. The North American Spine Society has issued coverage policy recommendation on laser spine surgery. Now, what is NASS? The North American Spine Society is a medical specialty society that I have a lot of respect for because, in part, it's multidisciplinary. Many specialty societies will have one discipline only within it. The North American Spine Society is one with many members, physicians and non-physicians, chiropractors, physical therapists, occupational therapists may be members. Among physicians, there are surgeons and non-surgeons, neurologists, physical medicine and rehabilitation physicians, sports medicine physicians may be members of NASS. And among surgeons, there are both orthopedic surgeons and neurosurgeons. The value of that multidisciplinary approach within this society is that any one discipline's or any one physician group's biases tend to be blunted by the influence of other colleagues. When they looked at laser spine surgery, and this was copyrighted 2014, I'm not sure exactly when the work commenced and finished, but around that vintage, they stated laser spine surgery in the cervical or lumbar spine is not indicated at this time due to lack of high-quality clinical trials concerning laser spine surgery with the cervical or lumbar spine. It cannot be endorsed as an adjunct to open, minimally invasive, or percutaneous spine techniques. This was in a coverage policy recommendation. In other words, a statement by this medical society that is issued with the intent of providing evidence-based guidelines or information upon which an insurance company can then make a coverage decision. So this is a group of physicians saying, we've looked at the evidence and it isn't there. We don't think healthcare resources should be spent on this, which might seem like keeping money out of their own pockets, but the point of all of this is that in medicine we recognize that it's important for us as a society to be putting resources toward things that matter and not be putting it toward things that are hype or may not be as helpful as they're marketed to be. And that was the intent behind this. So again, 2014. So we have this vision that we've described with the small Band-Aid incision and this idea that we'll get better quickly and it's minimally invasive. And we have this non-coverage recommendation from a multidisciplinary society where everyone spends all their time in spine. What do we make of that? So it raises the question, in this idea of getting back to work quickly, getting back to life quickly, is it really the laser that matters, or is it something else? This may be a little hard to read for some of you in the back, but if you think about different approaches to the spine, there are varying degrees to which we really invade the body, if you will. We can do a very small procedure, one that is percutaneous, and that's only about 0.04 to 0.08 inches, or 1 to 2 millimeters. A percutaneous procedure will involve a catheter or a needle, something of that size. So you're not really making a big incision, you're just inserting a small probe into the body. If you're doing an endoscopic procedure, you're making an opening that's about 9 millimeters in size or thereabouts, and that's 0.35 inches, to give you an idea, a little more than 1/3 of an inch. An endoscope is an instrument that has a light source so you can see what you're doing. It has a lens that allows the light, of course, to bounce back after it's admitted into this tiny space. And it also has a working port through which instruments can be inserted or removed so that you can do a desired procedure. There are microscopic procedures that can be done through tubes, and we'll show pictures of this as we go along. The openings here are a little bigger. They range from 16 to 22 millimeters, or about 3/5 of an inch to 4/5 of an inch in size. And then, of course, open procedures, which can be very large. From the base of the neck all the way down to, close to the tailbone for some procedures. So that's how we make an approach. We may use any of those manners that I've just described to get into the body. And then to actually do what we're there to do, we may use mechanical instruments, dissecting tools, drills, burrs, curettes, things of that sort. We may use electrical energy, cautery. We may use a laser. There are a number of different kinds. Those are just two that are displayed. We may use ultrasound. We'll use some form of electrical or light or mechanical energy to make a change inside the body. We can use any of these types of instruments or tools with any of the approaches, with few exceptions. Laser is a type of an instrument. It's a type of a tool. Use of the laser isn't what determines the size of the incision. What determines the size of the opening is the approach that's being used by the physician. The laser isn't what determines that. The laser is actually used for only a very small part of a discectomy procedure, or a very small part of a procedure in which a thickened ligament is being removed. It's not the main star of the show, if you will, but it does add cost. So when we think about degrees of invasiveness, and here I'll make some broad statements that I think generally comport with the literature, but if you look all the way to the left, I'm using the word approach. Open is the top, mini-open, tubular, endoscopic, percutaneous. They kind of go from biggest opening to smallest opening. We get the most direct visualization when we make a big incision. We have no direct visualization at all with a percutaneous procedure. Again, that's the one where we're using a small needle or a catheter. So the size of the opening I mentioned. The recovery time will be longest with a large open procedure, and will be the lowest, no recovery at all from any percutaneous procedures. But, and the complication rate with a bigger surgery will be higher if we make a bigger opening. We're seeing more tissue, we're doing more dissection, there are more opportunities for something to not go quite as planned. But we can take care of any problem with a big open procedure. Some problems we can take care of with a minimally invasive approach and a smaller smaller opening. But we can take care of everything with a larger opening. And some problems, some tumors, some fractures, some traumas really require a larger opening rather than a smaller one, depending upon the nature of what's going on. The success rate, though, and the recurrence rate are somewhat related to the size of the opening. So the very tiny openings tend to have a lower success rate, such as the percutaneous procedures. Also, there's some evidence to suggest that with an endoscopic discectomy, you may have a higher recurrence rate than if you have a microdiscectomy. But again, it is a smaller opening. So does 5 millimeters matter in terms of an incision? It's an open question, and there's still some open debate and room for people to write papers about that. So I mentioned degrees of invasiveness. I'll just describe it in this way. With an open procedure, we're making a big incision. A diagram is shown in the upper left, an actual photograph here below. Why would anyone do that? Well, if you have an x-ray that looks like the one we see to the left, if you have a posture similar to the back, there's two images of a woman's back, of course, at the top. If you have a curvature or an x-ray that looks like that, you may very well prefer to have this corrected rather than living with it. It may be worth it to you. How much pain are you having? Or when scoliosis becomes very severe, it can even interfere with a person's breathing capacity. It can cause weakness or numbness if a particular nerve is being pinched or if there is some impingement of the spinal cord. So there are any of a number of reasons that may compel a patient who has a deformity, as we'll call it. It's a rather unkind word, but a person who has a spinal deformity may very well elect to have an open procedure and be grateful for it. Just another image. A step down from that is what we'll sometimes refer to as a mini-open approach. Here, we're using a retractor that at the top involves a small opening at the skin, but which fans out below to show us 2 or 3 levels. So we still have a smaller opening of the skin, but we take advantage of what's called a lordotic curvature that most of us have in the lumbar spine to use a small opening, and by changing our line of sight, gain access to 2 or 3 different levels. The actual retractor that I use is up there on the upper left. Those are not my pictures. I borrowed those, but that gives you an idea of what the instrument actually looks like. Another step down from that is a tubular retractor. The idea here is that we can dilate sequentially to start from a very small opening and get to a larger one. So on the left in that diagram, if you look at the very bottom, there's a narrow tube, and if you look at the top where it's yellow, there's a wider tube. We'll start by putting on the narrow one, then the larger silver one, then the larger pink one, then the yellow one, and so on. What we get is a stack that, after we've advanced them all, looks a little like this. At the base is the retractor itself that's inserted over the stack. And then we take the stack of dilators out, and what we have is something that looks like this. This arm holds the retractor in the angle we want. And this is just a cable for a light that is shown at the top of this image. This gives you a bit of an idea about what we can do with these instruments, with these retractors rather. The image on the left shows a tubular retractor docked onto the spine as if we were gaining access to a facet joint. The image shows the retractor in 2 different orientations. We're able to get to the right side and the left side of the spine by changing the angle and getting to both sides through only one opening. And if we have to work at more than one level, we'll then have to make more than one opening. Typically, when I use these retractors, if I'm doing a discectomy, I'll use a 16 millimeter tube, which is a little bit bigger than 3/5 of an inch. If I'm doing a fusion, I'll use a 20 millimeter tube, which is 4/5 of an inch. So I'll review some of the literature, and this is not all the literature on microdiscectomy. Every paper that I will mention here did involve laser. So this is not a comprehensive review of spinal surgery. I'm just showing you some examples of literature that we have that has to do with laser approaches. This refers to a 2007 review of over 40 randomized trials of surgical management of lumbar disc herniation. And there are a number of quotes from this. Surgical discectomy for carefully selected patients with sciatica due to lumbar disc prolapse or herniation or rupture provides faster relief from the acute attack than conservative management. as physicians, we know that. I mean, we can solve the pain problem that a person may have in their hip, buttock, and leg by doing surgery. The question is, do they really need it? Because we also know that most patients who have pain from a disc herniation ultimately will get better without surgery. Most people who have a disc rupture don't need an operation. But if a person's really hurting, we know we can get them get relief of that pain faster with surgery. Any positive or negative effects on the lifetime natural history of the underlying disc disease are still unclear. Microdiscectomy gives broadly comparable results to open discectomy. That's also true. The incision before we moved to microscopes and tubular retractors was a lot smaller already than it had been in the 70s. And so as of the review of this literature, this review being published in 2007, there really wasn't a big difference. The microdiscectomy incision wasn't a whole lot smaller than the open discectomy incision, because the open discectomy incision, was already quite small. The evidence on other minimally invasive techniques remains unclear, and that would include endoscopic approaches and percutaneous approaches. 2008, survey of Dutch spine surgeons, 86 of 122 responded for a 70% response rate, which is pretty good. And so again, this is a survey of surgeons. There will be a surgical bias, of course, but the opinion here was minimally invasive techniques were expected to be less effective with higher recurrence rates, but less postoperative low back pain. A percutaneous or endoscopic approach was expected to give you less back pain. It's a smaller incision, but also expected to be less effective, lower success rate, and elsewhere higher recurrence rate as well was the general impression. A 2002 review of minimally invasive techniques indicated that each technique has its own complications and requires a long learning curve. That's certainly true with endoscopic work. Patient selection, disc morphology are important factors in the choice of technique. Here, getting at the idea that there may not be one size fits all. And I'll come back to that in some comments. Cervical spine laser surgery. Here was a small number of patients. Let's see, what was it? Oh yeah, just a single level procedure in 10 patients, 2-level procedure in 2 patients. Again, these are laser papers only. This is not a big paper, small number of patients. There was improvement, excellent to good. The big bar is good, not excellent. The white bar is excellent. So at the latest follow-up of these patients, there was certainly improvement for the majority, but the majority weren't getting excellent results. So the endoscope, I've mentioned that. The endoscope, as I mentioned, provides a light source, a lens so you can see what the light is illuminating, and a working port. It's much smaller, much less bulky, of course, than in a big operating microscope, which stands on the floor and has a big head that is on articulating arms that's held over the surgical field. The earliest iterations of endoscopy in the spine moved from this idea of tubular retractors and sequential dilators. So in that image you see in the upper left, the lower piece just shows sequential dilators. I've already shown you what those look like. The top is one of the earlier endoscopes, another depiction of the endoscope docked on the spine. Here we see an endoscope without any tubular retractor being used, and that was the migration from an opening that's about 3/5 of an inch to an opening that's about 2/5 of an inch. And here just shows you one in use in the spine, what it may look like. So again, a migration of a few millimeters. When we go from a microscope to an endoscope, we go from binocular vision to monocular vision. So depth perception changes. We can still simulate depth perception by moving the scope side to side or in and out and get a bit of an idea about what's foreground, what's background. It's not quite as intuitive as what we see under a microscope, especially for people who have very good three-dimensional vision. When we go from microscope to endoscope, we also go to making it sort of a 1 or 2 hand procedure, whereas we can take advantage of an assistant's help even with a 16 millimeter tube. These two images show an approach with an endoscope that requires making another defect in the disc. The disc, as you may know, has 2 parts. There is an outer rim that we see depicted in both of these diagrams as concentric circles or, ovoid structures. The outer strap, called the annulus fibrosus, is dense fibrous tissue that holds in place the softer cartilage in the middle. That softer cartilage in the middle is like crab or shrimp meat. It's tough. And a disc herniation occurs when a tear develops in that outer strap. This image here shows well the tear that led to some of the disc material rupturing out. But with this transforaminal approach, as it's known, the endoscope is inserted into the disc in a different spot, and you actually have to make a second tear to get in there. That's one reservation some people have about that approach. Another is this. These triangles are known as Camden's triangle. It's the area where we can gain access safely to the disc space. What we don't want to do is damage this structure, this structure, this structure. Does anybody know what that is? Yeah, it's the nerve. It's the nerve root. Let me ask you a harder question. I see Dr. Dykstra, he'll know this perhaps. I'm not going to put you on the spot. But there is a there is a thickening of the nerve here. We see it here. I don't know if you can see that, a little bulge that's depicted. And up here as well. There's a bulge in the nerve root. That's known as the dorsal root ganglion, and it's a very important structure. Inside the dorsal root ganglion live the actual cell bodies to the neurons that are involved in sensation, light touch. When the dorsal root ganglion is compressed severely, people can have just terrific pain. When people have what's known as a far lateral disc herniation, they're often compressing the dorsal root ganglion. And we as surgeons know that despite our best efforts, about 20% of people who have a disc herniation pinching the dorsal root ganglion will have some long-term numbness or burning pain. Thankfully for most people it's quite mild, but about 20, maybe 25% of people who have a disc herniation pinching badly that ganglion will have some residual symptoms despite our best efforts. With an endoscopic approach, you are coming in and blindly, you're not seeing, this isn't anatomy you see skin. You're inserting the endoscope toward Camden's triangle, You're inserting the endoscope toward the anatomy, but you always do have that risk of injuring the nerve root. And that is why many surgeons will prefer to do this approach with a patient not under a general anesthetic, but rather with sedation only, so that they can get feedback from the patient. I'm not bringing up these two concerns at all to say that this is a bad surgery. I don't want to leave that impression with you. These are rather concerns that have to be managed. I bring these up because they are concerns, and these are features of a procedure that need to be managed very well by somebody who's done a lot of these. And so that's the spirit in which I'm bringing it up. I don't want you to leave with the impression that the endoscope is a chip shot. It's actually, from a technical standpoint, there's quite a learning curve to doing this and to doing it well. So dorsal root ganglion is vulnerable, and I brought this up already. When we're working in that area, 20-25% chance of some numbness. So I think I've made this point already as well. But what do all these images have in common? They're all diagrams. They're not actual intraoperative pictures. because you don't really see that much. What you see the anatomy very well. The optics are fantastic, but the point is that when you're doing these procedures, you don't have an expansive view of the anatomy at all. You're using X-ray guidance and what you're seeing through the scope. You're integrating them together to tell you where that tip of the instrument is located. So it's a little different than doing microscopic surgery. This is what you actually see. Something like that. This doesn't do it justice. The optics really are very, very good. But the point is that you're not really getting a view of the spine as you would see in the diagrams. Again, it speaks to learning curve. It's important if you're having one of these procedures done that someone has done a lot of them. So just a little more literature on endoscopic laser discectomy. An early review at that point, the author of this review had only found 12 papers as of 2000. None were controlled or blinded or randomized. They were just case series. People had done some cases and reported on them, but there wasn't a comparison to earlier techniques or other techniques. The opinion of this author was, given the extremely low level of evidence, it's recommended that procedure be regarded as experimental until results from a controlled clinical trial, ideally with random allocation to an intervention and control group. Moving on a little later, this was a retrospective study, 2001, just a year later. A number of complications were mentioned. It's a big series, 958 cases. The complication rate overall, 2.5%, is low. Just bring it up to make the point that complications are possible with any surgical procedure. It's just something a patient needs to bear in mind. You should never have any surgery with anyone, no matter how high your opinion of them may be, unless you're really certain that other treatments have not been successful for you. I'll just move through some of these. I want to be mindful of the time. So moving to more recent literature, 2014, a retrospective review of 39 patients undergoing an endoscopic lumbar laser procedure provided satisfaction or better than acceptable, so good or excellent results in 94% of the patients who had not had prior lumbar surgery, and about 86% of patients who did have prior lumbar surgery, so pretty encouraging number. A prospective study of 66 patients who underwent surgery in the cervical spine, undergoing a 1 or 2 level laser procedure. Symptomatic improvement in 95% of the patients. 50% had 100% improvement of, quote, all cervicogenic symptoms. I put that in quotes. It's just a bit of a yellow flag. When you see that, it means that really the physician publishing the paper is getting to decide what is and isn't attributable to the neck. Small number had less than 80% improvement in this series. So it all looks very good. One of the concerns was, though, the mean follow-up was only 94 days, a little over 3 months. It's pretty short. We like to see a follow-up of a year to 2 years to really know what the recurrence rate is and whether the results are durable. So short-term in that study was certainly encouraging. Another 2015 study, a retrospective study of 134 cases. So someone did these cases and then looked back in the literature or in their own records to see how well the patients had done. In this report, 75 of the 134 cases had excellent outcomes, 49 were good outcomes, only 5 were judged to be fair. Follow-up was up to 5 years. Complications, 5 cases in this series with dorsal root ganglion irritation, so pretty low number. Again, an encouraging study. Now we'll talk about percutaneous approach. When we use the word percutaneous in spine, people are usually meaning one of a couple of different things. One use of percutaneous refers to fusion. When we need to insert screws and rods, one approach is with an open incision, such as I've already shown in prior images. This is a newer approach that we'll often use. Not every patient is a good candidate for this, but for those who are, it's great because it saves a lot of dissection. What you can see in these images is a tower that is inserted through the skin. The diagram on the left indicates what's happening. The tower goes through the skin. A little tiny stab incision is made with a scalpel. You don't do any more dissection beyond that. Under X-ray guidance, you insert the screw to where you need it to be located. The way we'll do this typically is we'll first place a needle that has a hollow core that we can remove. We then remove the core of the needle. We'll insert a little wire. We'll advance the wire a little further. Then the needle comes out. Then we'll use a tap. For those of you who know anything about woodworking or carpentry, you'll understand the importance of this. The tap is hollow, though, in the middle, so it can fit over the wire. We'll tap the hole, leave the wire in. We leave the wire in because the wire is what guides each instrument in and out. After we take the tap out, again, the wire remains in place. We'll put the screw in, and at the back of the screw is the rest of this tower. Then we'll insert the rod that, and actually I think I have a picture of that. Yeah, here we go. This is a rod that's attached to a handle, and then at the bottom it shows a sextant-like device. In fact, that's a name that's used for one of these systems. And fundamentally, we'll also insert the rod percutaneously. We'll weave it through each of the towers, and then a nut basically goes in through each of the towers. We tighten everything up. We detach the inserter from the rod, and we're also able to detach each of the towers. So what you're left with is the spinal instrumentation in place with very small incisions along the way. People will also use the term percutaneous when they're referring to discectomy or decompression. So the idea here is that a person can percutaneously insert a needle or a catheter into the disc space. The goals may vary. With some devices, you may be seeking actually to remove mechanically some of the inner disc material. With other devices, you may be seeking instead to shrink it using a laser technique or an ultrasound technique. Actually, ultrasound, you'll be obliterating some of the tissue and usually using suction or grasper to remove it. But these are ways of, without direct vision, inserting a probe into a disc space and removing some softer cartilage. The term decompression has come to be used more so for these procedures because it's a little confusing to use the word discectomy. Again, you're not normally going directly after the ruptured fragment, but you're removing some material right in front of it. And so as depicted here, you may not be removing the lump that's directly pushing on the nerve, but the idea is if you take some of the tissue out more safely and blindly on the other side of this lump, there may be less pressure on the lump, and with less pressure on the lump, less pressure on the nerve root. That's the idea behind this. So early literature on this back in 1998, there was the opinion percutaneous laser discectomy adds little to surgical armamentarium. It was a review in the late 1990s. A small prospective series of 10 patients with thoracic discogenic pain treated with this procedure. Their visual analog scale score. So when people ask what's your pain on a scale of 1 to 10 or 0 to 10, that's what they're talking about. Visual analog scale, 0, no pain, 10, the worst pain you can imagine. Their pain went from an 8.5 to a 3.8. It didn't get rid of it, but it took it from probably a severe pain problem down to something that was perhaps for many patients a manageable annoyance. This study had a good follow-up period, 24 months. That's nice to see. They reported no adverse events during this percutaneous procedure. It's a small series, 10 patients. There's no randomization. It was retrospective. It wasn't done prospectively. So, there are things that suggest this really isn't high-quality literature. It gives us a bit of an idea about what's happening, but a randomized prospective controlled trial is obviously what we love to see to really answer a question, is this or is this not an effective technique? But insofar as we can gain information from case series such as this, it's reasonably encouraging that you're getting moderate improvement for these patients. It's not a home run, but maybe a double or triple. 2013 review article assessed the quality of the literature, and as I just indicated, it indicated that the review suggested that the level of evidence is weak. These aren't high-quality studies. And they specifically stated that there just weren't enough randomized clinical trials to judge whether or not this is a good thing to be doing. The 2013 study, 22 patients, chronic low back pain and radicular pain. What we mean by that is the hip, buttock, and leg pain that may accompany a disc herniation. These people underwent this percutaneous procedure. Complete relief was achieved in only 21%. At least great relief was in only 63% of patients. So, again, not a home run. For some patients, it may be helpful. This study also had a shorter follow-up of 6 months. 2013 study, comprehensive evidence-based guideline for interventional techniques in chronic spinal pain, indicated that the evidence is limited for percutaneous lumbar disc decompression. There just, wasn't enough high-quality literature. A 2014 study, 21 patients undergoing a procedure, and they rated them on the basis of whether the pathology was in the front of the spinal canal here, which is actually a disc problem, or in the back from a thickened ligament. And perhaps not surprisingly, they found that about 2/3 of the patients who had a disc bulge in front of the nerve root bundle had good or excellent relief, and only about 33% of patients who had a thickened ligament behind the nerve root bundle or spinal cord had relief. Percutaneous laser spine surgery in a 2015 randomized prospective trial of disc decompression versus microdiscectomy with 115 patients in it was conducted. But for this trial, every patient had to have a smaller disc herniation. So it's a nice design in the sense that it's a head-to-head comparison of microdiscectomy with this percutaneous lumbar disc decompression approach. But they were only including patients who had the smaller disc herniations. A larger disc herniation might favor the microdiscectomy approach. So the study design here is one where they're clearly trying to make sure that they've sweetened the pot a bit for the percutaneous approach. What they found is that there was a non-inferiority of the percutaneous approach at 8 weeks and at 52 weeks. And this was designed as a non-inferiority study, meaning they were trying to find out of the gates, is this worse? They weren't asking the question, is this better than our existing treatment? They were trying to ask the question, can we say that this is not worse than our existing treatment? They did, however, find that there was a slower recovery with the laser procedure. Recovery, that is, of the radicular symptoms. They didn't get better as quickly. And more reoperations were required with the laser procedure. 38% of the patients with the laser procedure required more surgery. 16% of the microdiscectomy patients did in the series, and that's a little high. It's usually somewhere around 8 to 13% in that range, so this is a little high. But again, 38% of the laser patients needed further surgery. You could flip that around, I guess, and say, well, 62% didn't. But we don't know whether that 62% were kind of living along with good or moderate results, or whether they were really happy with how they were doing. Percutaneous laser spine surgery in a 2016 review article that assessed the quality of the literature was found to have weak positive recommendation for the treatment. Again, this has to do with the quality of the literature. One should expect that rehab would be needed even if you're having a minimally invasive procedure. People do better with physical therapy than without. It's not, up and playing tennis the next day. Let me come back to this controversy about laser spine surgery. What I will do here is run through a few quotes, and they're all from one article that was in Bloomberg Business in 2011. and it had to do with an article that was critical of the practice, Laser Spine Institute, that has done a lot of this marketing. These quotes are from the article and don't represent my opinion. They're just from the article, and I'm relaying them to you. I will offer my opinion later, but this isn't my opinion. This is from the article, okay? Is everyone clear on that? So in the article, it stated, laser spine is a part of a boom in ambulatory care centers with physicians and residents as owner practitioners. There are 5,000 plus such centers in the U.S., 90% with doctors as investors. Back surgery is a prominent part of the trend. Laser Spine routinely charges, and this was Laser Spine Institute, routinely charges patients $30,000 for its procedure, more than double the typical price for a decompression elsewhere. Patients have brought 15 malpractice lawsuits since October 2009. Again, this is a 2011 article. A period in which the company performed about 7,500 procedures based on its 2010 estimates. Nationally, outpatient surgery centers receive about 6 malpractice suits for every 20,000 surgeries, according to insurer Zurich North America. Aetna won't cover operations at Laser Spine, citing a lack of research confirming safety and efficacy. Cigna won't pay for the laser part of surgeries done there. Laser Spine says United Healthcare covers its procedure. 9 surgeons told Bloomberg Businessweek the company is doing surgery that is often unnecessary or inappropriate. The evidence that ablation helps patients is, quote, pretty weak, end quote, says Dr. Roger Chow, a physician at the Oregon Health and Science University and director of the American Pain Society's Clinical Guidelines program. Dr. Chow said, even in studies showing some benefit, the benefit is small and doesn't last. Founder James St. Louis, 56, was a year out of personal bankruptcy when he began seeking investors for the company in 2003, records show. Now he owns 7 cars, a $10.3 million Florida mansion, and an $8.3 million house in Aspen. He declined an interview request. Court documents indicate St. Louis was slated to receive a 25% stake in the firm, which would have entitled him to about $19 million of $77 million in distributions the company has made. Some patients say they've tapped retirement accounts or taken out second mortgages to pay Laser Spine's premium prices. There is significant controversy about laser spine surgery, as this technique has not been shown to have significant benefits despite advertising that may make you think otherwise. Often marketed in magazines and the internet, laser spine surgery has become the focus of some lawsuits for misleading patients about expected results from surgery. Again, those were all quotes from the article, not my opinion, but I'll share you mine again, but that wasn't it. So, in fairness, Laser Spine Institute does have a response, and if you want to hear more of what they would say about critical remarks, it's on their website, but I thought it was only fair also to indicate what they would have to say. Laser Spine Institute's procedures typically only require incisions of less than 1 inch. Unlike open back surgery, recovery doesn't require a hospital stay and has lower infection rates, 0.3%, compared to 4.5% in hospitals, and complication rates, 4% compared to 31% in hospitals. 50% of patients report returning to work within 1 month of surgery. 80% of patients return to their jobs within 3 months after surgery. 97% of patients would recommend Laser Spine Institute procedures to friends and family. So that's the perspective that they would provide. My opinion, I think it's a costly option to have laser procedure. The laser does add cost. It isn't clear that it adds any medical benefit to the procedure. It's my opinion that Laser Spine Institute has probably helped many patients, but the help that they have given to patients, I think, had not to do with the laser, which is what people may have been expecting but instead had to do with minimally invasive approaches that are used. So is it the laser that matters, or is it something else? It's something else. It's the size of the opening. I think the bottom line here really isn't whether the laser is used. At the end of the day, you want to get the right operation for your problem. If you have a problem that requires a big incision, you need a big incision. If you have a leaky radiator, having a hose replaced won't help you. You need a new radiator if it can't be repaired in some way. I'm not a mechanic. I don't know if that's a great metaphor, but I hope it conveys the idea. If you've blown your engine, you need a new engine. If you have a dirty spark plug, you need a dirty spark plug. Laser spine surgery is a phrase that holds with it some hope and promise, but it's important to realize that the laser isn't the important part of it. If you need surgery on your back, you should want to have it done in as least an invasive manner as possible that will also solve your problem. You know, if you've blown your engine and someone offers to replace a spark plug, that won't help you, right? You'll pay for the spark plug. They're still going to send you a bill, but it's not going to get you on the road. It won't get you where you need to go. If you have a dirty spark plug, all you need is a new one, right? You want to make sure you're getting, the surgeon will take care of this, but the best visualization to actually solve the problem that you have. You, of course, also want to have a well-qualified surgeon to help you with the problem, someone that you trust. These are references. I know no one can read them, but you know, we have all of that. So thank you for coming this evening. And yes, ma'am. Yeah, it's a good question. I don't know the direct answer to that. I think, you know, with respect to, I don't know what the Center for Medicaid Medicare Services policy is on coverage for laser spine procedures. I don't know that offhand. The reason I don't know that is I have not been compelled by the literature that I've reviewed to incorporate the use of laser into my practice. I don't do endoscopic disc procedures, the ones with a 9mm opening. I've gone to a number of courses where we do them on cadavers. I have been impressed that even though I've done thousands of surgeries in my career, this is a different approach. It's a new learning curve. And I'm going to go to a few more courses before I would consider offering it to a patient. I'm not convinced that it will ever be the dominant procedure in my practice. That technology may continue to improve. I expect it will. But, you know, the practice world that's probably highest on the learning curve is one that's closely associated with a company called Karl Storz in Germany. They make some of the best endoscopes in the world, arguably. I don't own any stock in them. I'm not trying to puff them. But there is a practice that's closely associated with them. And what they have found is that about half of their procedures are amenable to that 9mm incision, and about half just aren't. And so, you know, even if I decide to move from 16mm to 9mm, I'm not sure if losing binocular vision is worth it. I'm not sure if, you know, losing the ability to get more instruments in at once is worth it. But if I do decide to make that change, I'm anticipating only half of procedures I would use that way. So wandering answer, the bottom line is, for the laser part, I don't know because I'm not convinced it's really helpful and I don't use it. I think, you know, without any person's record in front of me, it's impossible to comment on a case specifically. But what I would say is, with respect to age, I think chronological age is less important than physiological age, if you will. You know, we all know people who are 90 who, you know, look like they're 65, right? And the opposite. And so I think if a person is judged by their family practitioner, their internal medicine physician, their cardiologist, pulmonologist, you know, if they're judged by either their primary physician or a specialist to whom their primary physician defers, if they're judged to be an appropriate candidate for a general anesthetic and a proposed surgery, then I think it's reasonable to consider it. The things I usually will suggest to patients that I meet with is one, if it's only a minor annoyance, any surgery isn't worth it, right? Even the minimally invasive surgeries have complications. They're real, they happen. You should never have surgery if the symptoms really are only a minor annoyance in your life. If the symptoms are having an impact on quality of life, if they're preventing a person from being as active as they otherwise would be, and they're really not getting better, then if surgery is offered by someone you trust, I think it's a reasonable thing to consider. With respect to your mom's situation, it's impossible for me to say whether a minimally invasive approach would or wouldn't be appropriate, but especially if one is, and if those other conditions hold true, I think it's something to consider. Sometimes we have to. So there are people who, unfortunately, may have either severe pain coming from a pinched nerve, from a problem completely unrelated to their cancer, and if their quality of life is so compromised, sometimes we'll have to consider that. Unfortunately, though, in some situations, depending upon the exact drug, it may need to be held in order to allow a person to recover well, and that can become a trade-off. And so it's a good question, and I'm sorry that you have to ask it, but there's obviously sorrow behind anybody who's asking that. But I think that I would say we do, but sometimes it involves holding the chemo, and it's something that's considered if a person's quality of life is so compromised that they have to consider it. Whether it's the tumor causing mischief or a separate unrelated problem that just, lightning struck twice the same person, Yes, ma'am. It can, certainly. So I'm sorry, I'm not repeating the questions. I was asked to do that. The question was, can scoliosis cause stenosis? Scoliosis is the term for the curvature in the spine. I showed several depictions of that in the larger cases. When the spine develops a curve that's abnormal, the forces on the spine are asymmetric. The muscles are doing different things on the right side and the left side. The joints are doing different things on the right side, the left side. The discs are doing different things on the right side and the left side. That asymmetry of force on the spine can cause arthritis in the joints. It can cause discs to bulge or herniate. It can cause even a shifting, rotational shifting, or a slippage, a translational shifting of the spine, any of which can result in a nerve being pinched. And so sometimes all we'll need to do is do a very tiny procedure and take care of the pinching without having to get involved with the scoliosis. Other times we'll need to do a limited one-level fusion along with a procedure to take care of the pinching from the stenosis. And other times, unfortunately, we'll have to think about a multi-level procedure depending upon what's going on. So, but it can, yes, it certainly can cause stenosis. Yeah, and what I would say is that there are so many potential variables when a person has stenosis and scoliosis together that I hesitate to make much in the way of a generalization beyond that. But depending upon the nature of the problem and the symptoms the person is experiencing, it can be treated either with a smaller procedure or they may need a very big one. It really depends on the specifics. So stenosis, the question is, when we're putting screws in the spine, what's the purpose? Why are we connecting them together? This talk really isn't specifically on fusion, but I'll try to give a brief answer. We like to let the spine move normally. We like to let the spine move normally whenever we can, because whenever you fuse two bones together, you will put more stress on the level above and the level below, and you're going to invite the possibility of further degenerative change occurring at perhaps an accelerated rate above and below. But there are times when we really don't have a choice. when people come in with a significant slippage in the spine, and especially when that slippage is changing to an unacceptable degree when they move forward, backward, bend right or left, in situations such as that, we will use screws and rods to secure the two bones together. We will often use spacers and graft material as well. The goal, when we find that the spine is out of an alignment to an unacceptable degree or has hypermobility or instability, these different terms that will be used, when we have to link the bones together, the screws and the rods are used to secure the two bones in place so that they don't move long enough to allow the bone to grow together between them. We'd rather allow motion, but we can't always. There are also times maybe the spine isn't out of alignment, it's not moving abnormally, but the stenosis is so severe throughout the entire course of a foramen or an exit canal for a nerve that we need to remove more than 50% of the joint behind it in order to clean everything out. And it's a general rule, but if we have to take more than 50% of the facet joint tissue, we have to take more than 50% of the joint behind a nerve root, we'll typically also recommend fusion because we don't want to trust that weakened joint to do the job of supporting the weight of the body. Sure. So the question is, how does a patient having taken bisphosphonates or other medical treatment for osteoporosis affect the surgery? And I'll kind of take that in two parts. Osteoporosis is, of course, a disease in which there's a decrease in what we describe as bone mineral density. Bone is pretty complex. There are proteins, there's a network of calcium, and there are cells, and there are multiple interactions among those structures. When the actual mineral itself, when the calcification of the bone goes below a certain threshold, we'll use the term osteopenia, which is an intermediate state. If it's even worse, we'll use the term osteoporosis. To overcome that, we'll use bisphosphonates or other drugs to try to reverse that trend if we can, or at least slow the progression. The medical treatment for osteoporosis really isn't a problem as much as the osteoporosis itself. When bone is weak, it tends to receive screws less effectively. When bone has a reduced bone mineral density, it tends to heal or fuse more slowly. The question is what I think of inversion therapy. I think I wouldn't recommend it routinely for everyone. I mean, I don't think everyone should go hang like a bat, every night when they sleep. I don't think that it's something that should necessarily be seen as allowing our bodies to, magically overcome the effects of gravity, on our body parts. But I also wouldn't say that it's fair to be dismissive of it. Inversion therapy or using either a table or specialized boots to in some way allow you to hang your body the opposite way is a way of achieving traction or distraction. Theoretically, it's a way to increase the separation in the bones of the spine. When people have impingement in a foramen, an exit canal where a nerve is leaving the spine, inversion or traction can be helpful, certainly, and many people get great benefit from it. One of the challenges can be, however, for some people with traction or inversion, however they deliver it, they may feel great when they're in it, but within 20 minutes of the release, they're just like they had been. This is completely unrelated to your question, but it's interesting, so I'll bring it up. I think Scott Kelly is the name of the astronaut who just came back after almost a year in space. And does anybody know how much taller he had grown? Yeah, 2 inches. Well, very quickly, within something like 36 hours, he was back to his pre-flight height. But what I found was interesting is he also said that toward the end of his time in space, he had this funny burning sensation as well, kind of throughout his whole body, on his skin. I'm not involved in his care. I have no idea exactly what's going on. It could be, some sort of a contact dermatitis, something that's irritating his skin. Or when I hear that term burning, it also makes me think of some patients who have a condition called tethered spinal cord. Patients who have spina bifida may have, well, I don't want to make this too long, but some patients will have a problem in which early in development there's an opening in the spinal cord. It gets scarred to surrounding tissue. When they're born, we'll need to close that to limit the risk of infection or nerve damage, but scarring can cause problems for these infants as they grow because the skeleton grows faster than the spinal cord. So the spinal cord is sort of stuck at the bottom. Obviously, it's attached to the brain at the top, but that stretching can give some of these patients symptoms similar to that. And I was sort of wondering if, in space, with his growth, if he was basically having a tethered spinal cord, he was putting traction on his nerves that, was thankfully alleviated pretty quickly when he came back to Earth. But anyway. How about one more question, and then we can wrap it up. Ma'am. So the question is whether something has to be done when a disc has blown out or herniated or ruptured. Yeah, right next to a fusion. The short answer, I guess I would hesitate to offer any specific opinion on a case, so let me offer a general remark. First, with disc herniations or disc ruptures, most thankfully don't require surgical intervention. The majority of people who have a disc herniation ultimately recover without the need for what I do. If, however, people are having ongoing pain, numbness, tingling, weakness that isn't responding to conservative treatment, then further treatment for the problem, I think, is reasonable to consider. Conservative treatment can include things like physical therapy, traction, injections. If those things are working, and if you've not been recommended to meet with a surgeon, I wouldn't be nervous about it. If those things are not working, your symptoms are more than a minor annoyance, and you want to know whether there are other options, then it's the sort of a thing I think you'd need to see a surgeon about. So, well, thank you all for coming. Hopefully this was informative. And to answer the question, to be direct, laser spine surgery or HYPE, laser is an accepted and effective tool in medicine. But in this application, I think it's often misunderstood, and I don't really think it has a role yet. Thank you.